before? Has anybody ever triaged in a mass cal? All right. So I've done a couple. I had the incident command one, and it's a cluster. It's always a cluster.
Yeah.
So I'm going to tell you kind of the ideal situation for how this should go down. Realistically, you do the best you can. So objectives, we're going to talk about how do you recognize a trauma patient, how do you treat them quickly in the field without getting too in the weeds on anybody. How do you identify potential problems, because sometimes what they present with isn't always what they end up needing to be rescued from. And then identifying your stressors of flight and anticipating problems kind of at altitude. And then how do you give handoff, like once you are kind of done taking care of that patient. So the who's of this, it's you, because anybody could be tasked with triage at any kind of time. And then the them is the patients that are needing triage. And then everybody else is who's available to help you. So the what's is how do you make a triage decision? And the when's, like, let's do it now. So triage needs to be kind of the first step before they get on the aircraft so that you know what you're working with. And then as far as where, you need to decide where's this patient going. So from a flight standpoint, that's kind of predetermined, but like on the ground, you want to know where's your trauma center, what kind of level of care do they actually require. There's different levels of trauma centers that can take, certain things versus, other things. Is it a burn center? Do they have pediatric capabilities? Is it a pediatric trauma hospital or just a peds hospital? Because they're two different things. Do they have neuro capabilities, cardiac? Do they have burns, hand doctors, eye doctors? They're all specific specialties that you kind of have to determine up front. Otherwise, you're just kind of setting that patient up for requiring yet another transport. And then additional resources. Do you need a NICU team? Do you need a burn team? Do you need a CCAT team? Do you need an ECMO team? Is there a pediatric doc that you need to have online with you? Do you have to have lots of rigs? Like, do you have multiple patients? So how many can you transport and what's actually your capability? Do you need police to secure the scene? Do you need fire? In the flight environment, it's more like, do you need security forces? Do you need the Ravens? Do you need, crash fire rescue? And then also on the civilian side, like, do you need SWAT? As far as level of care required, do they need to fly or do they need to go by ground? Again, that's more of like a civilian determination. Do they need BLS or ACLS? So in our case, our nurses are ACLS, so we should be able to handle to that level. So the whys, why do we triage? To allocate resources to do the most good. And then do you need additional resources? Do you know your capabilities and when you need more help than what you have available to you? And are we doing the most good for the most people? And then again, determining your transport destination, meaning like your trauma hospital, your burn hospital. So the hows, there's a lot of ways to skin this cat. There are a lot of triage systems, as you can see here. One of the ways that we all kind of universally as AE get trained is TCCC. So these TCCC cards that we have. In EMS, they use like the START triage. In the hospital-based system, they're using an ESI level. But realistically, it's like, how do you sort your patients sick versus not sick? So from an EMS standpoint, there's kind of a stepwise way of approaching a scene. So is your scene safe? In our case, no. Is it going to be? No. So we don't really wait for that. You have what you have available to you. And then your BSI is like your PPE. So, are you protecting yourself? Is this like a radiological event? Like, do you need to worry about like radiation in the area? Is this a chemical event? Is there like, bioweapons being used? So identifying like potential threats to you, because if you wind up getting sick or incapacitated, you can't help anybody. MOI and NOI is like your mechanism of injury versus the nature of illness. So like, are they trauma or are they medical, essentially? And what is it that actually brought them to you? How many patients do you actually have? And then do you need additional resources? Do you need security forces there? Do you need a CCAT team or a burn team? Once you actually approach the patient, do they need to have a C-collar? Because if we pick them up and move them and they've got like a high C-spine fracture, does it really matter what all we do to help them if they're gonna be a quad at the end of all this? Just kill me, like just leave me there. So what's your initial impression? So that's your sick versus not sick. So when you see them, do you go, oh shit? Or are you just kind of like, you know, I think we can work with this. And then what's your GCS and EMS, we call it AVPU, but essentially like what's your neurological status? What's your chief complaint? So what are your immediate life threats? So that's where you throw your March algorithm out there. And then, you know, running your ABCs, airway, breathing, circulation. So looking at those things. And then making a transport decision. So are they coming with us? Do they need CCAT? Are they dead and staying there? So kind of determining those things. So once you've identified this is absolutely a trauma patient, there's kind of a stepwise way that you look at that patient. Typically you'll start head to toe. So, you know, looking at their head, neck, abdomen, pelvis, look at their upper extremities. I always kind of feel here, and then kind of work my way down. And then going to your lower extremities and then making sure that you look at the back as long as there's not a reason not to turn that patient, like an unstable pelvis or an unstable, you know, spine. So what are you actually looking for? So you're looking for holes that don't belong there. You're looking for blood. You're doing that blood sweep kind of behind them if you can't turn them. You're looking for bruising, deformities, step-offs, being spinal step-offs. If you look at their back and you kind of run your hand down it, you can feel a step off. It's not like a subtle finding. You're like, oh shit, that's not supposed to be there. You're looking for edema, pain, anything abnormally hard or anything abnormally squishy is not generally good. Crepitus is like when you can actually feel like bone fragments moving around in there. Subcutaneous emphysema, if you have a hollow organ like your lungs or your bowel that bursts, what it'll actually rise and come through your skin as is it looks like little Rice Krispies and you can feel it when you touch it. That means something that was supposed to hold air is no longer holding air. Something that moves that shouldn't. So if this part of your arm is moving, that shouldn't do that. Something that doesn't move but should. Again, like if you have you know, dislocated your hip and you can't get it to move, that's also not good. Something that isn't there that should be there. Do they have all their arms? Do they have all their legs? Like check and make sure that you notice those things. And then after you've gone through all that, you make sure that you reassess. So how to triage? So pick a struggle. Like pick an ESI, pick a way of determining sick versus not sick. Assign an acuity. Are they critical? Are they, you know, walking wounded? Can they walk onto this aircraft or do we have to carry them? And then transport to the closest appropriate facility. So, you know, if it's like, well, they've got a burn, we need to go to BAMC, but you're in Djibouti, like, are you going to BAMC? Probably not. So triage systems, again, ESI is the hospital system. It's a level 1 to 5. So 1 is your most critical, so that's like your patient in cardiac arrest. 5 is like, they need a medication refill. 3 is more like, you know, your belly pains and stuff, and it's based on number of resources needed. So if they come in with belly pain, they're gonna need a line, lab, a CT scan, probably meds. So you're kind of basing it on like number of resources that you have to actually dedicate to that patient. MCI is sort of mass casualty triage. That's probably what we're going to be working with tomorrow. And then the objective of mass cal triage is to do the greatest good for the greatest number of people. So if you can't fix the problem or at least like temporize it in the meantime, kind of move on to the next. The START triage is simple triage and rapid treatment. And it evaluates respiratory status, perfusion status, mental status, and that's kind of how you break down like your prioritization of those patients. There's another one called MUC. It's for mass cal. It's annoying. We won't get into that one. It's a lot. It's just, it overthinks it. So again, their triage systems are designed to assign the highest priority to the patients that need the most help. and that's kind of what we're looking at. So non-life-threatening, who may be non-ambulatory, like they may have an ankle fracture or something, that would still be considered green. So that would still be considered. So even though they can't necessarily walk on of their own accord, are they going to die from an ankle fracture? Not today, probably. And let's see. So during the initial phase of triage, so medical intervention should be limited, but there are still things that we can do. We can manually open an airway. You can place, you know, an OPA or an NPA. You can do a needle D on the chest if you determine that's, you know, required. Administration of a chemical antidote. So like if they've had like organophosphate exposure, we'll get into decon in a minute, but like once they've been deconned appropriately, you can treat that. And then external hemorrhage control, so wound packing, tourniquet placement, stuff like that. And then any intervention that immobilizes the provider should be avoided. So like if you're sitting there and you're just like, I'm gonna have to manually hold airway opening for this patient, crank them. Because you're not, realistically, you're not taking yourself out to just hold this guy's jaw in a jaw thrust. So this is kind of how we're gonna do it tomorrow. This is sort of the TCCC approach. We're gonna use some form of triage tags. So most likely when, you know, the team gets there and they're delivering patients to us, they should have some kind of a handoff on a paper. And so ideally it would be like a TCCC card. From what we know from yesterday, we got just like a copied, hand jammed kind of like, here's the location of their injuries kind of thing. We're gonna use a modified like triage tag system because we don't have actual triage tags. So Newbie and I are gonna get some tape that's gonna designate red, yellow, green. And essentially, green are your minor injuries, yellow is delayed, so they need some care, but they're not dying on this aircraft today, ideally. Red, they need some kind of immediate intervention. They're sick, so they need help, and we need to help them along the way. Black is expectant, so they're expected to die, and so we don't have the resources to care for them. We can't fix what they've got going on. They exceed the resources of this aircraft and this crew, so they're going to be left behind. So we'll talk about that in 1 second. So field term criteria is basically, how do you make that determination of black? Like, how do you just wipe your hands of a patient, you know? And it's pretty specific. So resources needed exceed capabilities of crew. Like this patient, we can't, they're so messed up, they can't be fixed with a needle D and, you know, 4 tourniquets. Like they're gonna exceed what we are capable of doing for them. Is the patient in rigor mortis? If they are, they're not coming on the aircraft. Does anybody know what dependent lividity is?
It's like a line of, you know,
yeah,
discoloration.
Yeah. All the blood kind of pools down.
Yeah, exactly. They've been laying there for a while, the blood has kind of settled, and when you turn them over, a lot of times they'll be black, like against their scapula and their butt, because that's sort of the lowest point. If you see that, they're not alive, they're not coming with us. And then generally a traumatic arrest needs an intervention that's greater than we're capable of providing. So if they have arrested, they need like a pericardial centesis, they've had some kind of aortic injury. It's something like, we're not cross-clamping anybody's aorta out here, so they're going to die if they're already in cardiac arrest by the time that we get to them. The other thing too is brain matter exposed, and this one is one that I've actually encountered in civilian life where if you have an open skull fracture and you have brain matter coming out of it, a lot of times that patient will have a pulse and they will still be breathing, but they are very much not alive, nor will they survive this experience. So if you see anything on the back of their head that looks like oatmeal, don't take them. So triage intervention, so like what can we actually do at the time that we're triaging? Stop the bleed. So dart the chest. I apologize ahead of time. This presentation's like 80% for me to show you guys EMS memes, because I think it's like 3% actual information. So stop the bleed. You can dart the chest. Maintain CMS. So like if they have a deformity and like a foot's going the wrong way, we can't like get that back into the joint space, but if you have to splint that foot so that you can get it in a position that you get a pulse back, you should actually try to do that. So we're not reducing anything that's dislocated, but if it's not in a position that's like physiologically viable, you can actually try to move that foot into a position until you get a pulse, as long as you're not taking an excessive amount of time to do it. Keep the patient warm. That's a huge thing for us. Stop the burn. So if they're burning, make sure that they're not still burning. That could actually be the case in some instances. And then decon. Again, if they've been exposed to something, the last thing that you want to do is expose your crew, expose the pilot. So if there's any determination that there could be a decon situation, that patient's not getting into the aircraft. Airway adjuncts, so OPAs, NPAs, whatever you need to like hold that airway open. Meds, do they need epi? Do they need nitro? Dextrose, is their blood sugar low? Antidotes, so again, like if they've had like an organophosphate exposure, like we can give them the 2-PAM and the atropine to try to get them kind of back online. Narcan, again, is an antidote to opiates. You can get a cyano kit. Again, this isn't stuff that we carry, but it's something that we could request potentially. So when people are in like enclosed burn spaces, any plastics that are burning, they can actually get cyanide toxicity, and so you can give them a cyanide kit, and that can help. It's another sort of antidote. So once you assign an ESI level, can you reevaluate that? According to the hospital, no, but theory goes, once a level's assigned, you can't change it, but realistically in our environment, that's a changeable thing. So they may have been assigned a yellow, and then once you get them back in the aircraft, we could have absolutely missed something. So do they have a hole like in their backside that they're bleeding out of? Well, we might have triaged them a yellow, but realistically they're a red. And so we're not necessarily changing it, but we're upping our level of suspicion that this guy needs, resources that are going to be a lot higher than what we initially determined. A good example of this happens in the hospital a lot, is a patient comes through triage, they come in with like belly pain, and it's just like, okay, sir, like there's a lot of people waiting, like you can wait, you can get your belly pain seen by the provider, as soon as we get to you. Well, that belly pain could be, not because he ate too much McDonald's, but because his aorta's dissecting. So, your now level 3 patient is like really a level 1. So, ruptured ectopics are an example of like a, chronically mislabeled diagnosis. So they'd be, diagnosed as a 3, but realistically they need a lot more resources than that. Liver lax, again, AAAs. Wounds get missed, stories change. That's really common, especially like civilian side, they'll come in, they'll be like, I have chest pain. It's like, just kidding, I need a pregnancy test. So stuff like that happens. But reassess your damn patient. Like, please, like, look at them, ask them questions, get the whole story from them. So AE-isms. So there's not a lot said in AE about like triage systems utilized, but we do have a couple of guidelines. So what I found is the ERPS flight surgeon can serve as an AE consultant for triage. Dude, I don't trust them. I mean, I would still kind of triage your patient again. I think that, a lot of times we'll see them by the time that they get to us, what we were told the story was is very different than what the story actually ends up being. So let's see, and that's also only true if you're picking up directly from the ERPS. So, if it's brought into us and they're coming from point of injury, don't be like, can we get an ERPS flight surgeon out here to like triage for us? Like, no, we're gonna do it. And then the ACM may assign a higher as an upgrade classification of a patient. So we can up triage, but again, we can't down triage. So if they were determined to be a 1 alpha, we can't just be like, no, just kidding, you can just walk on, buddy. So, and then a patient's condition will not be downgraded without approval from the validating flight surgeon. So again, we're not formally downgrading them or, upgrading. We are just sort of saying, like, we need to keep a closer eye on this one. And then once the time has come, we finally landed, we finally arrived, and we're ready to give handoff. You want to make sure that you're giving handoff in a very concise and directed way. So in EMS, we use the MIS report. So what you're reporting really is your mechanism or your medical complaint, injuries or illness identified, signs and symptoms that they had, so like, their GCS, their vital signs, and then any treatments that we did, so any lines that we placed, fluids, medications, kind of what their response was. So we're not asking how they take their pills, we're not asking how well do they ambulate, so this isn't like a hospital report, it's literally just, here's what's happened, here's what they actually have wrong with them, this is what they were demonstrating that, determined our plan of care, and then here's what we did, and that's about it. So it should take 15 seconds realistically, even for a very sick patient. So these are just like a couple little pearls that, I've kind of learned, in my career is sick versus not sick. And my way of teaching you that is going to be very vague. So we were talking about this earlier. Medicine is an art and a science. And so we can teach you the science part of it, and we can say, oh yes, assign an ESI level, and here's how you do that. And we can tell you in a very stepwise fashion how to mitigate that. And in the very beginning of your career, that's required. I mean, you can only follow an algorithm. As you sort of progress and see more patients, you develop more of the art of it, where it's just like, there's a disturbance in the force, like over here. I don't like how this is feeling. And you just have a gut instinct. And I will say 1,000% trust your gut. And one of the things that I've learned, throughout my career is that transport equals instant karma. So if you are taking shortcuts, and if you have it in the back of your head, should I put a tourniquet on that thing? Should I, should we put this guy in a litter? Should we move him? Should we place a backboard? It's like, no, that seems like a lot of extra work. I'm not gonna do that. That shit's gonna bite you in the ass. So you wanna make sure that, like, if you have it in your head, let's go the extra step for this. A lot of times that winds up saving your ass. I can tell you a story just real quick about a guy that we got that was a jet ski accident that they pulled out of the river. And EMS said over and over, there's no blood. And we're looking at this guy and, man, there's no blood, but he was pale as a ghost. And he just looked really, really bad. And I looked at my partner and I was like, I want to put a tourniquet on that. And he was like, what? He's not even bleeding. Like, why would you put a tourniquet on it? And I was like, I'm gonna do it. So we put the tourniquet on, and sure as shit, as soon as we got him warmed up, gave him some blood, gave him, some fluids, and got him, kind of working again, he started bleeding. And because we didn't have the blood flow to the area, we couldn't really determine how tight to turn it, crank the tourniquet. And this guy 1,000% would have died if we hadn't put the tourniquet on. But it was just like that looks really bad. There has to be some more involvement than what we're actually seeing. That's your karma, man. So like, if you decide like, nah, it's not worth the time or effort, like take the time and the effort to actually do it. If you have something inside of you saying like, I feel like there's something weird here, trust it. And so pediatric patients, kids look good and then they die. So kids will compensate, and then they will fall off the cliff and they'll die on you. So just because their vital signs look good doesn't mean that they're good. So keep a very, very close eye on them. If they have a high reason for like suspicion that they're actually sick, like trust that they're actually sick. And then old people look bad and then they die. So they look bad all the time. They will look like the crypt keeper and they will just keep churning, and you will think like, oh yeah, they're fine. And then all of a sudden it's like, oh man, she really did look like shit. And yeah, she'll die on you. And then again, go with your gut. And then don't forget to check the back. So if you have a reason to think that, this patient has a gunshot wound in their shoulder, make sure it's not coming out back here. So take the time, again, follow through with the karma and check the back, make sure that you don't see anything additional back there. And then do you load and go or do you stay and play? And this has to do with like the karma of everything. It's like, do you just take one look at them and say, nope, they're good to go, and load them onto the aircraft? Or do you say, I feel like we need to put that tourniquet on before we actually load them? Or I feel like we need to, restrain this guy. I just have a bad feeling about it. Trust that. And then just a note about the golden hour. That being said, with your instant karma and your staying and playing, you do have a limited window to get these patients to an actual trauma surgeon. And your golden hour starts from the time that they get injured until the time that they are in the OR opened up with a surgeon. So everything that you do on the ground takes time away from that golden hour. So make sure that the interventions that you're doing and the time that you are taking are worthwhile to that patient. That's it. Any questions?